I thought your mic going on, so I thought you were going to ask some questions. Okay, right. Who is the next presenter?
So I'll present, sir.
Kamal Pandian. Where are you from?
Yes, sir. So I'm from Chennai, sir, Ambattur.
Chennai. Where did you do your UG?
Sir, UG from foreign countries, Central America, and I did my internship from Kanchipuram GH, and then joined PG in NGM Healthcare, Amjikare, and now in Miot, sir, for a secondary degree.
BA where?
MGM Healthcare, sir, Amjikare.
Oh, you and Damodaran are batchmates then.
Yes, sir.
Yes,
Yeah,
sir.
we both. Yes, sir.
Okay, right. Go ahead. What
Okay,
is
sir.
your
So
topic?
the topic is on cirrhotic patient posted for a both bone fracture, forearm both bone fracture, sir.
Forum. That was the question in the last KD question paper. So what is the answer you will write if such question is repeated when you go for your theory also?
Yes, sir. So to start with, we'll start with an introduction defining the cirrhosis. So cirrhosis is a chronic progressive liver disease which is characterized by fibrosis and altered liver architecture. So it can affect multiple organ systems, including the hematologic, renal, cardiovascular, and the central nervous system. And usually these patients are at risk of coagulopathy, encephalopathy, aspiration, hemodynamic instability, and also they also have an altered drug metabolism and response. So this on the surgical part, the both bone fracture or if it's going to be a short surgical procedure, which can be done under regional anesthesia. For the considerations, the in the pre-op evaluation, we need to elicit the history of the patient, which includes the etiology of the cirrhosis, either it's alcoholic or viral, and if there are any past decompensations for the patients, including ascites or GA bleeding or encephalopathy, and what the patient's current medications on. Usually, they'll be on diuretics or lactulose and beta blockers, and with the patient's examination, we need to look for signs of jaundice, ascites, edema, astraxis, or if the patients look for the patient's nutritional status. Also, look for the patient's oral hygiene and a variceal bleeding or something. Going to the investigations part, we need to ask the patient for CBC, where we can find if the patient is anemic or thrombocytopenia can be seen. Also, we need to look for the liver function test where there'll be an elevated bilirubin levels. Also, there'll be a low albumin level. We can also look for the ALT and ALT levels. Importantly, the coagulation parameters, because the PTINR might be deranged in these patients and the APTT is also increased. And we need to watch out for the renal function test to diagnose if there's any hepatorenal syndrome in these patients. There can be electrolyte imbalances, hyponatremia, hypokalemia. Also, a child or a MEL score. Severity in these patients, and a routine ECG, echo, and chest X-ray where you can see there are any fluid overload or pulmonary edema or other things, and ABG if needed. So usually these patients follow ASA 3 or 4 depending on their liver function. And pre-optimization in these patients is really important, where we need to correct the coagulopathy, FFP, vitamin K, or platelets if their platelets is less than 75,000, or we need to treat ascites by giving diuretics or paracentesis if needed. And we need to prevent encephalopathy, provide lactulose, and we need to avoid sedatives in these patients. Electrolyte correction has to be done, glucose monitoring has to be done, and there has to be a strict NPO for at least 6 to 8 hours pre-op, and aspiration prophylaxis has to be provided for these patients. We need to also discuss with the gastrointestinal team, hepatology team if needed in an advanced case. So intraoperative, we would prefer a regional anesthesia in these patients because it's far more safer and we don't disturb the hemodynamic stability. And the preferred method would be the supraclavicular or an infraclavicular ultrasound guided block. And these usually avoids the hepatic drug metabolism, and also less cardiovascular and respiratory impact is seen through this. But the main drawback of this is going to be if the patient has a coagulopathy, where their INR is going to be more than 1.5 or platelets less than 75, it's going to be difficult. The second option would be general anesthesia, but here the induction could be either through etomidate or a low dose propofol with a titrated doses can be given. And muscle relaxants, the choice of drug would be atracurium or cisatracurium, which is mainly a non-hepatic metabolism. And also, we can maintain these patients through sevoflurane or isoflurane. Analgesics would be fentanyl over morphine, and which is fentanyl being a short-acting and hepatic safe drug. And we need to, if providing a general anesthesia, we need to make sure that the airway is secured and a rapid sequence induction is preferred if the patient has ascites. In the intraoperative management, standard ASA monitoring, including the ECG, SpO2, NIBP, and we need to consider an arterial line if the patient has an advanced disease. Also, fluids, cautious use fluids, and the preferred fluid would be the balanced crystalloids or albumin. We need to maintain a normothermia and normoglycemia throughout the procedure, and blood products if there is an elevated INR in these patients. Make sure to avoid the hepatotoxic drugs in these throughout the procedure. And the post-operative care is going to be mainly for the pain, and paracetamol at lower doses can be given, or a regional anesthesia for these patients. Make sure to avoid NSAIDs if the patient has risk of renal damage or GI bleeding. We also need to monitor them for the hepatic encephalopathy, bleeding, renal dysfunction, and we need to provide DVT prophylaxis if it is not contraindicated in these patients. We need to make sure to make them early ambulate, and high nutrition diet should be provided. And the special considerations in this category of people would be they'll have a drug metabolism, altered drug metabolism, which means a reduced dose, and they'll have we need to increase the interval for the drug delivery. And they'll also have a risk of aspiration, so their gastric emptying time would be increased, encephalopathy, and these coagulopathy can limit the use of regional anesthesia in these patients. And the hepatorenal syndrome can also occur, and we need to monitor the urine output, and we need to avoid the nephrotoxins in these patients. That's it, sir.
You finished? Okay.
Thank
right.
you.
You have covered almost all the points, but there is one important thing missing in that. Can anyone or you yourself tell me that? It was a very fairly complete answer, I would say, but one important point is missing. What is it? Dr. Bindu, Ranjini, Kayal, whoever wants to answer can answer. I'm not seeing your faces, I am seeing only your names. Safely hiding. Last batch students were bold enough to show their faces and presence. I don't know why you are all hiding. Do you have to do any risk stratification for any surgery in this patient?
Yes, sir. So yes, sir. So yes, sir. So the child put
what are the risk stratification scores you know of?
Sir, the child put code score, sir.
CPT score, very good. That was the oldest one. Then
and also MELD score, model
MELD score, very good. And MELD score. Any recent ones over these two old types of scoring systems, you know?
MELD NA, sir. MELD NA.
MELD NA, yeah, that's a slight modification of MELD. MELD sodium or Na. Then you know what is MRS? Focal pen score. Have you heard of those things?
No, sir.
Oh, okay, right. I'll just show you the answer for that.